Good morning, all. And moving ahead from basic hepatology to advanced hepatology, we have none other than Dr. Ravi Mohanka to talk on liver transplantation. Earlier it was seen only in the textbooks, but it's become quite common now. And as such, for any modality, patient selection and timing of the transplant is very, very essential. To walk us through this, we have Dr. Ravi Mohanka, pioneer in liver transplant. Over to you.
Thank you very much. So today we'll talk about liver transplant, when to do it and who needs it. So there are generally, if you look at all liver diseases, we can divide them into two broad categories. One is chronic liver disease, and we commonly call it cirrhosis, and the other one is acute liver failure. And then there is an overlap where you have acute liver disease or acute liver failure on top of chronic liver disease, which is ACLF, which is the most dangerous type of liver disease that we deal with. And then there are some liver diseases that do not have liver failure. So these are the four broad categories in which we encounter patients and for which we need a transplant. Now, we have gone from a stage where liver transplant was only successful in 25% of cases, which was in the 1960s, to a point where we got about 70% success rates with transplant, that was in 80s. And now we are at a stage where we command a success rate of 90 to 95%, and we are looking at more and more innovations in transplant now. So even if you assume that there is a success rate of around 90% for liver transplant, when do we actually offer it to our patients is when their liver disease itself carries a risk of more than 10% to their life. So if the predicted 1-year survival of a patient because of their liver disease is predicted 1-year mortality is more than 10%, that is when the risk benefit is in favor of a transplant, because the risk of transplant itself is now less than 10%. Broadly, if you look at all liver diseases, almost 70% of diseases that require a transplant are chronic liver disease or liver cirrhosis, about 20% acute liver failure, about 10% ACLF, and the rest is only about 1%. Now, this is changing because the chronic liver disease is actually increasing recently. As we know, we go from healthy liver to a cirrhotic liver or to liver cancer typically between 20 to 30 years. And most of these patients will end up being in the stage of cirrhosis without decompensation, which is a compensated cirrhosis, and almost none of these patients will require a transplant. So only about 5 to 10% of patients who have cirrhosis actually require a transplant. Only the ones who have liver failure, which is liver decompensation. That is also because although the liver cells, the hepatocytes, are normal in a patient with liver cirrhosis also, but because they are entrapped into nodules, they are unable to regenerate. And that's why we end up requiring a transplant for these patients, because of failure of regeneration more than anything else. Now, broadly, we divide them into lifestyle diseases, which are metabolic associated liver disease, which is fatty liver and such. Then chronic viral hepatitis, such as hepatitis B and C. And then there are others which are less common, but these two are more common. Now, these etiologies have been changing in the last few years. We have very good treatment for hepatitis B and hepatitis C now. In fact, curative treatment for hepatitis C, which has been almost revolutionary in the last 5 years or so. But unfortunately, both alcoholic liver disease and metabolic associated liver disease is increasing at an alarming rate, to a point that it is becoming like epidemic. The other diseases such as autoimmune, Wilson's, vascular diseases, cholestatic diseases are less common, but nonetheless we do encounter them off and on. On the other hand, in children, it's biliary atresia, which constitutes almost 80 to 85% of all liver diseases requiring a transplant. The other ones are less common. And then there are about 20% patients where we do not know the cause. And for lack of a better word, we call them cryptogenic. Basically, it means that we don't know the cause, and we will probably never be able to find the cause. If you split up the chronic liver diseases, you will notice that now almost 45 to 50% of liver diseases requiring a transplant is because of non-alcoholic steatohepatitis or alcoholic liver disease, and the importance of hepatitis B and C are decreasing as we go along. And then there are other diseases which require a transplant. Now, when somebody has liver cirrhosis, if they have compensated cirrhosis, which means that they have liver cirrhosis but do not have symptoms of liver failure, they have an average lifespan of 10 years. So these patients will not benefit from a transplant because for them the risk is less than the risk that you're taking for transplant itself. So the only time generally when you will suggest a transplant to somebody is when they develop one of the decompensations which are listed there: jaundice, encephalopathy, ascites or variceal bleeding. Because the moment you develop one of these for the first time, your expected survival goes from 9-10 years to about 1 year, and that is when transplant benefits over your medical treatment. And if they develop an infection in the ascites, the survival goes down to 9 months. The moment you have effect on the kidneys, renal dysfunction starts, it could be as less as few weeks to few months. And therefore, in these, once the patient develops one of these complications, the benefit of survival outweighs the benefit of the continuation with medical therapy. Now, to objectively look at these, you use something called as CTP score, which all of us are familiar with, where we give scores based on bilirubin, albumin, prothrombin time, ascites and encephalopathy. And depending on what the score is, you get graded into one of the classes A, B, C, and then that determines what's your survival. Now, anybody who has a CTP class of C, their expected survival is about 60% at 1 year, and that's where the expected benefit with transplant is much more compared to medical treatment alone. The other thing that we use is called as a MELD score, and although it's a complicated formula, most of us, you will use a simple online calculator, feed in those values and you will get your score. Now, so we started off with using a MELD score, then we started using something called as MELD sodium score. Now currently we use something called as MELD 3 score, 3.0. And it includes, in addition to these 4 parameters, gender as well as albumin. So it's a little more accurate compared to the original MELD score. Now MELD score can go from 0 to 40, and 6 to 40. And you will notice that the moment your MELD score goes above 19 or above 20, there is a significant increase in the mortality. And that is when your expected benefit with transplant is more than medical therapy. So generally the cutoff is between around 14 for liver transplant in general, but for a living donor transplant it's actually even lesser. So the transplant benefit starts at about 10 MELD score for a living donor transplant, but for a diseased donor, a cadaveric transplant, it starts at about 14. So anybody with a MELD score of more than 14 or a child's score or CTP score or class of C, they will benefit from a transplant much more than medical therapy. There are certain diseases in which these scores don't work well. For example, PBC, PSC, Wilson's disease, alcoholic hepatitis and such, and there are dedicated scores for those. So in those diseases, you may not use the standard MELD score or CTP score, you may use one of these scores. So for chronic liver disease, in short, if somebody has a MELD score of more than or equal to 15 or a child's score of 9, or if they develop first episode of one of these decompensations, you should start thinking about a transplant. They may not need a transplant at that point, they may need it down the line, or they may even improve and they may not need it at all. But this is the time to start thinking about a transplant so that they get it at the right time, because often we end up in a situation where patients are too sick for a transplant at the time that they get ready for it. So this recommendation was given in 2008, many years ago, and generally still holds even today, that when somebody's MELD score or CTP score goes above a certain number for adults, you should think about a transplant. Or in children, the scores are a little different. Instead of a MELD score, we use something called as PELD score. But in children, one of the important things to consider is failure to thrive. So if the growth of the child starts getting affected, even if their numbers may not be so bad, a transplant is indicated in these patients because they'll catch up their growth very quickly. The second disease we talked about is acute liver failure. So acute liver failure is happens in a patient who has no pre-existing liver disease. Their liver is essentially normal, and it generally, unfortunately, happens in young people. Now, we divide the acute liver failure depending on the jaundice encephalopathy interval into 3, into hyperacute, acute and subacute. The hyperacute is within 7 days of jaundice encephalopathy, then 8 to 28 days and more than 29 days. Now, the most common etiologies for hyperacute are different from subacute. So the presentation depends on what is the etiology. Fortunately, the ones who have the most dramatic presentation, the hyperacute ones, are also the ones who will most likely recover and not need a transplant. So the ones with paracetamol poisoning, retol poisoning or halothane toxicity are most likely to recover, or hepatitis A or E. The ones with subacute liver failure, for example, drug-induced liver injury and some other ones, methotrexate toxicity, these are less likely to recover unless we stop the inducing agent in time. The two common reasons why we encounter this kind of acute liver failure in our country is one, anti-tuberculous medicine, and second is complementary and Ayurvedic medicines. Now, for complementary and alternative medicine. So for these two, I would request everybody to please monitor their liver function tests, and the moment they become abnormal, to see a hepatologist or a gastroenterologist, because these are very preventable problems. And unfortunately, a lot of these patients end up with liver failure which requires transplant, but they are very preventable. Again, in about 20% of patients with acute liver failure, we never find the cause, and instead of cryptogenic, we give them another fancy term called as indeterminate. And again, we don't know, and it's impossible to stop the progression of these diseases. So again, the distribution of transplant acute liver failure patients requiring transplant, drug-induced liver injury, very common in our country. Hepatitis A and E are becoming less and less common because a lot of these patients will recover. And we don't have a lot of paracetamol-related acute liver failure like they do in the West. So those are the other patients who will recover really well. So there are several prognostic criteria, like we have the MELD score, we have criteria to determine which patient is likely to recover spontaneously and which patient is likely to require a transplant. King's College criteria is the most famous one, which most people in the world use, but they are becoming increasingly less relevant now because they were primarily based on the Western etiology of acute liver failure, which is paracetamol and others. In our country, it is hepatitis A and E, which is the most common, and therefore, in our country, it may not be very relevant, and there are several other criteria that can be used. One of the most interesting criteria was by Dr. Acharya was the Alfred criteria, which is a dynamic criteria. So you keep looking at the patient's condition over time and see how they are behaving, and depending on that, you decide whether they are likely to recover or they are likely to require a transplant. The third situation is acute and chronic liver failure. And here again, although hepatitis B reactivation was a big problem in the past, it's becoming less and less of a problem. But unfortunately, severe alcoholic hepatitis is, even in very young people, as young as 20 to 30 years of age, is becoming a serious problem in our country. And it constitutes a large majority of patients coming to us with acute liver failure. For acute and chronic liver failure, all your regular ICU scores such as SOFA score and Apache score and similar scores specific for acute and chronic liver failure have become more reliable than the other scores. And here the problem is that these patients have a very, very high risk of mortality, sometimes even with transplant. So therefore, and these patients will go into multi-organ failure very quickly. So as long as the patient has up to 3 organ failure, these patients may be good candidates for transplant, but the moment they have more than 3 organ failure, these patients may have a high mortality even with a transplant, and it may not be worth doing. Again, we have several scores, but there are online calculators to calculate those scores and get an idea of whether they need a transplant. Then there are uncommon diseases which really don't cause liver failure, but then we have metabolic and some other uncommon conditions for which we do a transplant. And then there are liver tumors. So the most common liver tumor for which we do a transplant is HCC, hepatocellular cancer, in adults, and hepatoblastoma in children. Now this is the only cancer which can be cured with a transplant. There is no other cancer of any organ for which transplant is curative. And we are increasingly trying to use it for other cancers such as cholangiocarcinoma or colorectal metastatic disease also. Now, what is the logic behind doing a transplant for HCC? Because almost all patients who develop HCC is in cirrhotics, almost 80% of them. Now, the goal is not only to treat the tumor, but also the cirrhotic liver. Because as long as there is cirrhosis, new tumors will keep developing. So therefore, to treat both the HCC and the cirrhosis, transplant is the best option, and a total hepatectomy takes care of that. Now, initially we started doing transplant, like this was in 60s, we started doing transplants for all HCCs, and a lot of patients recurred. Then we realized that if you do it for small tumors or limited number of tumors, we get great results. So this was the Milan criteria, where we started doing transplants for lesions up to 5 centimeters or limited tumors, and we got very good survival, almost 80%. Then it was modified to another criteria called as UCSF criteria, where the size was a little more liberal, and then also we got very good results. And then subsequently there have been several criteria by several centers in several countries, and they've all worked really well. Basically, once you map these criteria on a graph, you realize that depending on how aggressive your criteria is or how liberal your criteria is, that is the kind of 5-year survival you will get. So the more conservative criteria, you will get better outcomes. The more bigger the tumors you offer transplant for, you will get worse outcomes. With time, the number of transplants in the world are increasing, and they are at this point, only in US, there's about 10,000 transplants every year. And you are all aware of what type of transplants we do, cadaveric and living donor. There's a big difference in the type of transplants that are done in different parts of the world. So while in US or most of Americas, it's almost 90% cadaveric transplants. In most of Eastern countries such as ours and Korea and Japan, it's almost, most of them are living donor transplants. So this is how we evaluate a patient for transplant. We do a detailed cardiac, pulmonary and fitness and to look at contraindications. Typically, if they have severe heart disease, severe lung disease, active infection, active psychological problems, or in acute liver failure, irreversible damage to the brain, we will not offer a transplant to them. We need to also determine what is the urgency of transplant, whether it's an emergency or an urgent transplant or a routine transplant. And then you also have to look at how difficult is the surgery likely to be. So looking at all these parameters, we determine that. So it's a very successful modality for patients who need it, and it should not be done too early in the course of liver disease, but it should not be delayed to a point where it's futile. Thank you very much.
Thank you, Dr. Mohanka, for giving a good insight into the for the indication as well as the whom and when to transplant. The question is the forum. Okay. Any question or comments from the audience?
Thank you, sir. That was a very enlightening talk. I had one question. In patients with acute liver failure, because King's College criteria is designed for paracetamol poisoning patients, correct, and we don't have that type of phenotype. So do you use the Alfred score? Is that what your preference is now for acute liver failure or
so
not?
Alfred score is only for hepatitis A and E. We only use it for A and E. For drug-induced liver injury, so now the King's College criteria have also been modified. The NHS criteria are the new criteria, which was in 2018, I think. They are divided into favorable etiologies, non-paracetamol. Non-paracetamol indications are divided into favorable etiologies and unfavorable. For favorable etiologies, you have to have encephalopathy, and the other criteria are there. For unfavorable etiologies, you don't even need encephalopathy to diagnose ALF now. So we use the NHS criteria, new NHS criteria, which are what is used for instead of King's College criteria even in the UK now. So those are the best criteria, but they also don't work for A and E. So for A and E we use Alfred. For all non-A, non-E, we use the new NHS criteria.
Thank you.
Sir, can you, sir, briefly guide us about post-transplant immunosuppression? They require lifelong immunosuppression?
Absolutely. So, for all liver transplants, patients require lifelong immunosuppression, but it is the most tolerant organ in the body compared to kidney, liver, kidney, heart, lungs, or any other organ. So, typically the amount of immunosuppression we use is around 25% of what you would use for a kidney transplant. So, it's really not an issue. Sometimes we use very, very little doses of immunosuppression. That is one. Two is that we know from our experience that about 20% of patients you can withdraw immunosuppression. Currently, we don't have a good test to determine in which patients we can withdraw. So therefore, we don't do it actively. For all practical purposes, the immunosuppression is very low, or you can even withdraw it. So one of the things that I was actually going to say is that we are starting the liver transplant program at Midas also. We've already got the permission and we have started screening patients. So hopefully we'll be able to, have our results in the next meeting.
Ravi, nice talk. If the patient's INR is more than 4,
yes,
is it taken as an indication when the patient presents as acute liver failure?
Sir, if the INR is more than 6.5 alone,
okay,
then it is an indication for transplant, except for A or E. A or E, I would accept a INR which is higher, or even retol. So A, E or retol, even a higher INR may not be an indication for transplant. Or non-A, E retol, a INR of 6.5 alone, or if the INR is more than 3.5, but they have other two things, lactate and HE and all that, then I would consider them.
Thank you. Thank you.
Transplant is a big topic. Doing in 15 minutes is a commendable job. So what the last time you told us the same thing. The transplant should be late enough to give a patient opportunity to have a complete survival without a transplant.
Yeah.
But it should not be that much late that surgeon will not have anything in hand.
Correct. So it is a problem because it's very subjective and it's based on your experience. So therefore this judgment is very difficult to make when the right time. So unfortunately, sometimes because of that reason, people tend to do it too early also, and sometimes you end up waiting and being hopeful and offering it too late also. So this is a subjective thing and sort of judgment call actually. Yeah.
Thank you very much.
Thank you.
Yep.
Thanks.
Thank you very much, Dr. Mohanka, for that lucid talk.